That was great. Thanks. Next up, we have the retort from Dr. Matthew Price. He is assistant professor at the Scripps Translational Science Institute and director of the Cardiac Catheterization Laboratory at Scripps Clinic. And he's going to talk about not considering patients for left atrial occlusion.
Matthew, thank you. Yeah, so I've been asked, Brian gave a great discussion on why we should be occluding or ligating the LAA in patients with CHADS scores of 2 or more. I've been asked to present the argument why this should not occur, that everyone with a CHADS score of 2 or more should not be considered for LAA occlusion or ligation. Yeah, we're not advancing forward here, I have a lot of build, which is unfortunate. So these are my disclosures. I perform LAA occlusion and ligation and have received honoraria or proctoring honoraria by those companies. So yeah, I have builds, but I'll tell you when to go forward, okay? To keep the comic timing appropriate. Go forward, one please. Thank you. So, you know, Brian gave a great presentation. I mean, this is a miraculous device. You're stopping people from taking rat poison. They're living 5 years free of bleeds. How can you argue against such a miraculous proposition? Forward, please. So it's like Mother Teresa. I mean, who could argue against Mother Teresa? You know, it's interesting that, I don't know if you know the history of the devil's advocate, but it was instituted by Pope Sixtus V in the late 1500s. And the job of the devil's advocate was to, when individuals were being beatified on their way to sainthood, their role was to show that the miracles were frauds, that in fact these people should not get beatified. So if you can go to the next slide, next forward one, please. So actually, to Pope John Paul II's credit, he invited the noted anti-theist Christopher Hitchens to testify as the devil's advocate against the beatification of Mother Teresa. Mr. Hitchens lost that argument, unfortunately. Next slide, please. So let's talk about PROTECT AF. And we saw a version of this slide, impressive. This is the result of the PROTECT AF trial, the primary efficacy endpoint numerically lower, a p-value of meeting its criterion for non-inferiority. Next slide, please. But you know, this is a Bayesian non-inferiority analysis. So if anyone in the audience can explain to me how to perform a Bayesian non-inferiority analysis, please raise your hand. Okay, so, all right, good. Next slide, please. So, and Brian also commented on the patient risk factors. Now, it's important when you look at CHADS2 scores across trials, is that the appropriate way to report a CHADS2 score is a median score. It's a nominal variable. So you don't take the average CHADS2 score, you take the median CHADS2 score. And also, the fact is that in the PROTECT AF trial, 1/3 of the patients who were randomly assigned to the Watchman device were a CHADS2 score of 1, low risk for stroke. And what does that mean? Next slide, please. So a low-risk population biases towards the finding of non-inferiority in a trial. If you have a non-inferiority trial where no one has events, of course your intervention will achieve its non-inferiority criteria because neither arm will have events. So that's why the FDA said this is a non-inferiority trial and you have low CHADS2 scores. That's why we need to look further. That's why you need to do another study, the PREVAIL study, in higher risk patients because it's a non-inferiority study. Next slide. And these are the clinical studies of the Watchman to date. We have the PROTECT AF trial. We have CAP2, the continuing experience. We have ASAP, which is 150 patients in Europe who were treated with dual antiplatelet therapy alone in a prospective fashion. And then we have the PREVAIL trial. Next slide, please. I just have a back of the envelope or on my iPhone, back of my iPhone edition here. So we have clinical outcomes data on 1,885 patients with the Watchman, with approximately 1,400 of these patients receiving a device, the other receiving medical therapy. Next slide, please. So let's cover the novel anticoagulants, dabigatran, rivaroxaban, apixaban. There have been 3 large randomized trials of patients who were candidates for anticoagulation: RELY, ROCKET-AF, Aristotle. Next slide, please. So you have clinical outcomes data for 50,578 patients. Next slide, please. Let's summarize the current status of the data. Next. So with the Watchman, you have 1,185 randomized clinical trial patients studied in a non-inferiority fashion. That's taking the PROTECT-AF study, patients who received both a device or Coumadin therapy, as well as PREVAIL, not including CAP2, which was not randomized. Next slide. Malaria device. We have an 85-patient single-center observational study in Poland. There is no randomized clinical trial. Next slide. Next, thank you. You have the ACP, the ampullary cardiac plug. There's a small observational registry that was for CE mark, approximately 200 patients. There's no randomized clinical trial, although one is embarking here in the United States. Next slide. Let's look at anticoagulant data summary. So there's nearly 42,000 patients who have been enrolled in superiority trials. And there's been an additional 14,264 in non-inferiority trials. So the ROCKET-AF trial was a non-inferiority trial. That trial had high CHADS2 scores. It's the highest CHADS2 scores of the 3 trials. I think the median CHADS2 score was somewhere in it was 3, I believe, or 3.2. So that's why that's a good non-inferiority trial, because it's a high-risk population. Next slide. Therefore, 47 times more patients have been studied in a randomized clinical trial with the newer anticoagulants compared with the Watchman device. 47 times. Next slide. Infinitely more patients than the Lariat or the ampullary cardiac plug for randomized clinical trials. There's a data imbalance. Next slide. So then you can break down. We saw this. You know, he said, well, we have back, please. Back. Excuse me, sir. Thank you. Go back one. Go back. No, you're going forward. You need to go backwards. Thank you very much. So these are the breakdown of the primary efficacy endpoint of the PROTECT-AF trial. And you see here, no difference in ischemic stroke after the peri-procedural period. A patient did have a stroke before they were randomized, before they got the device implanted. The major difference is in hemorrhagic stroke. That's an important thing. You don't put patients on anticoagulants, they have less hemorrhagic stroke, 1.6% versus 0.1%. I want you to focus on that 1.6%, put that in the back of your mind. But you know, if you say, well, that's why you're putting in this device and not a new anticoagulant, let's look at the actual data. Next slide, please, sir. Well, let's look at hemorrhagic stroke in the RELY study. So even with high-dose DABI, your mouse is on the slide. Thanks. So even with, thank you. Sorry about this. So with 150 DABI, you had a significant reduction in hemorrhagic stroke. In fact, the relative risk reduction, 74% relative risk reduction, significant p-value. I'd also note, if you look at the 1 year, I don't have a mouse here, but if you look at the 1 year follow-up, which is like PROTECT-AF, the absolute risk of hemorrhagic stroke and warfarin is actually quite low. Next slide, please. Let's look at the Aristotle trial. So this was apixaban versus Coumadin. If you look at hemorrhagic stroke in the center of the screen, 0.47 versus 0.24, 50% relative risk reduction in hemorrhagic stroke. And again, percent per year of hemorrhagic stroke in this large trial, 9,000 patients getting warfarin, 0.47% versus 1.2% in PROTECT-AF. Big difference. Next slide. Here is the ROCKET-AF, a non-inferiority trial, but appropriately so in that it's a high-risk population. Hemorrhagic stroke, 40% relative risk reduction. Again, the absolute event rate of hemorrhagic stroke and warfarin was only 0.4%. I'm not saying that's not high. I'm just saying compared to PROTECT-AF, where you had this humongous difference, you had a uniquely high hemorrhagic stroke rate on Coumadin. Next slide, please. We can say, well, you know what, Matthew, I don't even want to give my patient an anticoagulant. They're high risk for anticoagulants. I'm going to give them dual antiplatelet therapy. There's data from Europe, the ASAP trial, taking 150 patients, They all got the Watchman device. They only got aspirin and Plavix after the procedure. No Coumadin. They followed them up, I believe, for a year. You see here in the white is the observed ischemic event rate. The stroke rate in that study was 1.7%. The 150 patients. The expected rate would be 7.3%. Next slide, please. But there's only 150 patients in the study, and I haven't seen the 95% confidence interval for the stroke rate. What was the upper bound of the 95% confidence interval? Next slide, please. So then you can say, well, that's fine, but maybe the data is limited, but I still don't want to give my patient an anticoagulant because I'm afraid of bleeding, right? That's why I want to give them dual antiplatelet therapy. Next slide, please. Well, first, it's a big trial, more than 5,000 patients, of apixaban versus aspirin alone in patients who were not suitable for warfarin. First, they found that apixaban significantly reduced stroke and systemic embolism, and lo and behold, the bleeding rates were exactly the same between aspirin alone monotherapy and apixaban 5 milligrams twice a day, 1.4% per year versus 1.2%. The number of cases of intracranial bleeding was spot on the same. Provocative. Next slide, please. And also, you're not doing your patients any favors by giving them dual antiplatelet therapy in the setting of AFib. You'll get only a modest reduction in ischemic event rates. Same bleeding rates in the active W trial. Same bleeding rates between warfarin and dual antiplatelet therapy. You're not helping your patients. Next slide. So who wants to do that? Then the answer is, well, your patient doesn't want to take a pill every day for the rest of their life. They're young. Let's put something in there, make it definitive. They don't have to take a pill. That's the benefit. But there's also the upfront risk of the procedure itself. Next slide, please. So would you want to take a pill a day or a quick detour to the operating room? This is actually an RV puncture doing a pericardial access procedure. Next slide, please. I got this off the internet because we're not putting in ACPs yet, at least where I am. And this is you want a pill a day or a ACP in the left ventricle? That's a good question. Don't ask somebody who knows a lot about these procedures to give the devil's advocate. They can show some bad things. Next slide, please. So in summary then, the efficacy data for LAA occlusion devices are based on either nothing or a fraction of the patients studied with the newer anticoagulants. The presumed benefit in hemorrhagic stroke with devices may be overestimated because of a high risk, a high rate of hemorrhagic stroke in the control arm of the PROTECT AF trial, and is mitigated by the newer anticoagulants. So safety, and also finally, safety is either unknown or quite dependent on operator experience. Next slide, please. So where do we go from here? I think data is required from many more patients before LAA occlusion can be considered first-line therapy for all patients with a CHADS2 score of 2 or more. Next slide, please. Then again, if you can, I'm going to walk through this, so just when I finish each sentence, you can go to the next part. Then again, I have a 43-year-old friend who is an interventional cardiologist. Next, please. And he actually had an onset of paroxysmal atrial fibrillation on his way to giving a left atrial appendage occlusion talk. Next slide. He took rivaroxaban prior to a potential cardioversion, and he was afraid to shave or drive his German sports car. When his CHADS2 score gets a little higher, he would rather have an LAA occlusion device. Except he needs to find someone as good as himself to put it in. Brian, make sure you're available for my phone call in a few years, okay? Thank you very much.